Okay, we are live. I'm Dr. Shannon Clark. If people can let me know if they hear me. And then also once Dr. Montes joins us, just let me know. There she is. Let me add her. I'm gonna send you a request, Doc. Add in.
Hi,
Hi.
lady. How are you?
I'm doing well. How are you?
I'm doing great. Thank
Good.
you.
Dr. Montes agreed to this kind of at the last minute because I realized I had some time today, so I really appreciate you doing this.
Oh, yeah, for sure.
I just want to start off by saying, guys, this is a very complex topic. What
Mhm.
we're going to go through is based on what ACOG recommends, SMFM recommends, but what we also want to say, and I'm sure you agree with me, that there's still room for individual management on a case-by-case basis. So if your doctor did or did not manage you according to what we're saying, there's probably a reason why. You could always ask. But, it's not like we pull out a book and say we have to do X, Y, and Z. We have to also look at the individual and determine if different things can be done or, am I making sense,
Right.
right? Yeah, we
Right.
still have to take
Exactly.
it. Yeah, we have to take it on a case-by-case basis. So what we're going to
Right.
talk about today is early pregnancy loss. And hopefully, if we get to it, we're going to talk about recurrent pregnancy loss a little bit, also the management of early pregnancy loss. And then I wanted to try to throw in subchorionic hemorrhage because I get that asked a lot about that. And then
Sure.
hopefully a little bit about MTHFR mutation because those are probably the two most common questions I get in conjunction. So first of all, doctor, please introduce yourself. Tell everybody who you are.
Thank you so much, honey. I appreciate you
Mhm.
inviting me to join you. My
Yeah.
name's Erica Montes. I'm a board certified OBGYN. I've been practicing now for 8 years, and I am in Scottsdale or Phoenix, Arizona.
Okay.
I went to med school in San Antonio in
Mhm.
Texas. And I did my residency at Parkland Hospital or UT Southwestern in Dallas.
Mhm.
And then I came straight over here to Phoenix. My husband's a physician and he's from California and I'm from Texas. So we
Yeah.
kind of split the
So, and then,
difference.
yeah, split the difference,
Yeah.
right? And tell
So
everybody where they can find you on social media.
yes. So my handles at the dot modern dot mujer, and mujer means woman in Spanish. And I basically just talk a lot about health, not as much as Dr. Clark. I mean, her page is amazing, but
Thank you.
health, a lot about, medicine, med students, empowerment, things like that. So if you want to join me, I'll be happy to see y'all there.
Well, and the other good thing that I really love about your page is you do a lot in Spanish, which I think is
Yeah,
really great. So
thank
she does
you.
share her information a lot in Spanish for those of you guys that are Spanish speaking and want to get your information that way. She's a great resource for that. Okay, so let's
Thank
dive
you,
in.
honey.
So
Okay,
let's just
sounds
talk
good.
about the definition of early pregnancy loss. And basically,
Right,
we went through this document and we're just going to go through. And this is basically what ACOG has a new technical bulletin. That's kind of
right,
like these guidelines that ACOG puts out on early pregnancy loss. So it's defined as a non-viable intrauterine pregnancy with either an empty gestational sac or gestational sac containing an embryo or fetus without fetal heart activity within the first 12 weeks and 6 days of pregnancy. So that's considered an early pregnancy loss. But
right.
Doc, we're trying to use the terminology early pregnancy loss now, but what are some of the other common terms that are used to describe a loss that
Right.
early?
So, we use a miscarriage, of course, is like the most common one that is out there that every person knows what that means. We do tend to use the word spontaneous abortion. And I know anytime someone hears the word abortion, it's like,
Abortion, yeah.
no, no,
Yeah, yeah.
it's not, this isn't what that is. But spontaneous means it's a miscarriage, it's happening spontaneously. And then, I think those are like the main two words.
Yeah.
Those three common words are what we use kind of interchangeably.
Yeah, but I think we're trying to move towards the early pregnancy loss.
Right.
And just about the abortion thing. So for abortion, it's spontaneous abortion, which means it occurs spontaneously, and then we have the term elective abortion where a woman chooses
Correct.
to do an abortion electively. But because abortion has such a negative connotation, when we use it in medical terms, both spontaneous abortion, if people don't understand that, they think that it means something negative or that we're saying
Right.
they chose to terminate their pregnancy, which is not the case. So that's where we're kind of trying to go away from using the term spontaneous abortion.
And then, of
Okay.
course, there's also medical abortion, which,
Yes.
is something that we recommend and
Yes.
we want the patient to get it for certain different chronic conditions.
Right. Right. Okay. So let's talk about the different types of early pregnancy loss. What is a chemical pregnancy?
So a chemical pregnancy is something that I think it's more common nowadays because we have such a high sensitivity on our home pregnancy
Yes.
tests. We can actually detect an HCG level between like 20 to 25 milliunits per milliliter now. And so that level is super, super low, super early. And so some women may not even know that they have a chemical pregnancy, but it's basically when you are late on your period, you take a pregnancy test, it comes out positive, and then a couple days later you start bleeding like your normal period, and then your test subsequently quickly after is negative. So, you know, there's different reasons. I feel like most of the reasons for the chemical pregnancy is just due to a chromosome anomaly. And so, you know, it's at such a early point in the development of this embryo that it never even though it implants, it never continues to grow or develop.
Yeah, so it goes far enough to cause an elevation in your pregnancy hormone levels or HCG levels,
Right.
but it occurs in less than 5 weeks. And the important thing is we're assuming it's because of chromosomal abnormalities, which
Right.
it probably is, but we don't have anything to test. So it's
Right.
not like we can do anything to test for sure what causes an a chemical pregnancy.
Right.
But biochemical pregnancy is another terminology that it's used for. But again,
Right.
so two things, like you said, the sensitivity of the home pregnancy test is crazy now. I mean, we could test really early. And the second, with the use of IVF, we know more because women are pursuing
Testing
IVF and
earlier.
assisted reproductive technology. They're testing early. So we know a lot, you know, women are having more biochemical pregnancies. Let me back up. I don't think they're having more. We're just recognizing it more.
Correct. Exactly.
Right? So it's not that they're having more. It's just that we're recognizing it more based on having IVF or having the pregnancy test. But many women just may have a late period and never even knew. Okay.
Exactly.
So with biochemical pregnancies or chemical pregnancies, we do not consider them in a recurrent pregnancy loss workup because nothing developed in the pregnancy or in the uterus that was ever seen on ultrasound. So that's why, and probably because it was chromosomal to begin with. So that's why they're not considered in a recurrent pregnancy loss workup. Right. But for fertility docs, though, if someone keeps having them over and over and over again, like multiple, which is rare that a woman would have multiple recurrent biochemical pregnancies, they may consider doing a recurrent pregnancy loss workup. But that's mainly for the fertility. Do you ever do a pregnancy loss workup or recurrent pregnancy loss for biochemicals or chemicals?
Not really, because you're right. I mean, I literally just had a patient this week who said she came in and she said, I had a positive pregnancy test, but I started bleeding, you know, like 4 days after I would have had my period. And so we did a UPT at the office and it was negative, but I said, let's just do an HCG because I'm curious to see if it's still going to show anything like below 25, and it came back 7. So yes, she did actually indeed have a chemical pregnancy, but like you said, I don't tend to see this recurring very often. So I told her, I said, this may be just like a one-time thing. Let's just kind of monitor you and go from there. But no, I don't.
Yeah. Okay. So, and same for me.
Yeah.
Whenever someone comes to me with a history of pregnancy losses, I go through each one to determine, you know, and ask certain questions to see what exactly was seen on each one, if it was a pregnancy test, if they ever had a heartbeat or not. So that's important to know.
Right. It's important to know, like, was it super early or was it like at, you know, 10 weeks and then there was a demise? All that has a role into kind of what classification we put patients in and kind of what workup we should do.
Yeah. My very first loss was a chemical pregnancy loss. Of course, I was trying and I got a positive pregnancy test, and about a week later, of course, I was testing right on the dot, which happens a lot. And I had a positive pregnancy test, and then probably a little bit less than a week later, I started bleeding. So that was, and we never saw anything on ultrasound other than a thickened lining, and you know, it is what it is. Okay, let's go to an embryonic or a pregnancy or a blighted ovum. So I'll take this one. So basically you get what you see is that you have a positive pregnancy test, you go in for an ultrasound early, and you see a gestational sac that forms and grows, but the embryo never develops. Okay, that's called an embryonic pregnancy or blighted ovum. And it's thought that these types of pregnancies make up about half of all pregnancy losses. So, and again, if it's early enough, you may not even realize it if you didn't go get an ultrasound, and you may go on to miscarry. But, you know, even if you get an ultrasound and you see a gestational sac, but it doesn't progress along that further than that, then it is going to be a blighted ovum. So, and we'll talk more about management here, which is one of the reasons why I brought Dr. Montes on, because I will say I don't ever manage women with pregnancy loss because I'm maternal fetal medicine. Later
they're already, exactly.
So I also wanted to throw in here ectopic pregnancy. Talk about what is an ectopic pregnancy.
So an ectopic pregnancy is basically when a pregnancy.
Oh, wait, time out. Let's talk. We're blighted
It's
ovum,
okay.
sorry,
Yeah, go
and
ahead. Go
are
ahead.
considered in a recurrent pregnancy loss workup because you did
Yeah,
see something on ultrasound.
exactly.
You did see a gestational sac and it didn't develop. So those are included in a recurrent pregnancy loss workup. Okay.
Yeah, and
Sorry, I wanted
really,
to, yeah.
yeah, I know. Okay,
Yeah.
really quickly, just to finish up on embryonic pregnancies, what we tend to see is if women are, looking at their ultrasound and they're, into like measurements and things, usually we tend to find that the gestational sac is about 20 millimeters
Mm-hmm.
or 2 millimeters, 2 centimeters,
Yeah.
excuse me, with nothing inside the sac. And so at that point, it's kind of like we should have already had a yolk sac
Yeah.
or a fetal pole. And so we
Mm-hmm.
call it an embryonic pregnancy.
Mm-hmm. Right.
Okay, as far as ectopics
Ectopic.
go, yeah, I obviously will manage this more and see this more than Dr. Clark, so
Mm-hmm.
I'm
Mm-hmm.
definitely happy to talk about this. So ectopic pregnancies are basically when a pregnancy implants anywhere other than the uterine cavity. So, you can have it in the cornua, which is like the area between the tube and right before you get into the cavity. Of course, the most common place would be the fallopian tube, but you also can have it in the cervix, an abdominal ectopic. I've never seen that before, but that
I've had
is,
a few.
you have had some,
Yeah.
I think, and we see that like more with IVF
Yeah.
because of
Yeah.
how they,
Mm-hmm.
introduce the embryo and things. But basically, that's what it is. It can be a life-threatening emergency.
Mm-hmm.
I feel as though we see that more like in residency because of the patient population,
Yes.
whereas like in private practice, patients are more attuned to coming earlier
Mm-hmm.
to see us, and so we kind of catch it early. So management is different depending on the case, but obviously there's certain risk factors, and so that's something that we kind of want to be checking out for.
Yeah, and you said they mostly about 90% occur in the fallopian tube.
Right,
So
exactly.
are ectopics considered in a recurrent pregnancy loss workup?
I wouldn't say so,
Yeah.
because I mean you get pregnant. It's
Yeah,
just that it's more
in
of
an
like an
abnormal location.
anatomical.
Yeah.
Yeah,
So no, they're
exactly.
not. They're not because yes, they can. Once you have an ectopic pregnancy, your
Hmm.
chances of having another one increase,
Hmm.
based on the reason why it occurred in the first place. Was there scarring in the tubes? Did something
Right,
is there something going on with the tubes that caused that? But
right.
no, it's not the same. And the same basket for recurrent pregnancy loss as the other ones, so that an
Right.
ectopic would not be considered in a recurrent pregnancy loss workup. Okay,
And
let's
then,
talk. Yeah, go ahead.
oh no, I was just gonna say, and like for risk factors that we tend to like really
Yes.
focus on, are gonna be smoking does
Mm-hmm.
increase your risk because of inflammation that it can cause, and it doesn't allow your tubes to be the motility is less.
Mm-hmm.
Your age actually
Mm-hmm.
can increase. IVF increases your risk, of course, and then also we are seeing more because of higher incidence of STDs, especially
Yeah.
chlamydia
Yeah.
is the STD that really increases your risk, and then also an increased risk of IUD use and
Mm-hmm.
sterilizations.
Okay. Yeah. So that's one of the potential complications of a tubal ligation.
Hmm.
Could be an ectopic pregnancy. Okay.
Exactly.
All right. And molar pregnancy or hydatidiform moles. Talk about that briefly and whether or not it's
Yeah.
considered in a recurrent pregnancy loss workup.
With as far as molar pregnancies go, I mean, it's mainly, again, it comes back to the chromosomes and the way that everything kind of your partner's chromosomes and your chromosomes kind of join and connect and things. But basically, what we see is that there's kind of usually the patient presents with like a larger than gestational size uterus. So like, if you think you're 6 weeks, you actually measure more like 10 to 12
Mm-hmm.
weeks on
Mm-hmm.
exam. Some women also they always tend to present with like bleeding. They sometimes can have a lot of pain because they
Mm-hmm.
can form large cysts on
Cyst.
their
Yeah.
ovaries, right? The thecolutean cysts. And then also patients sometimes if their HCG levels are super high, they actually can have some issues with like
Yeah.
thyroid storm and things like that. But usually for those to diagnose that, we usually see a certain appearance on the ultrasound,
Mm-hmm.
but we also really diagnose it like post DNC or after we actually remove the tissue, and then we see it on the pathology results. But no, I mean, I wouldn't, as
Yeah.
far as that goes, I wouldn't
Yeah.
say
It's
that
not.
goes with recurrent.
Yeah, it's not considered a recurrent pregnancy loss because those are
Right.
likely to not recur.
Right.
And then, I added ectopic pregnancy and molar pregnancy in there, but they're managed different than the ones we completely managed differently.
Right.
When we talk about management here for early pregnancy loss, we're not going to talk about management of ectopic and molar. I just wanted to add that in here for one reason, mainly because of what is considered a loss. I think, and we won't go into this in detail because that's really not what we're here for, but a
Hmm.
loss is a loss, in my opinion,
Right.
meaning how you feel about it emotionally and mentally. Women still grieve when they have an ectopic, when they have a molar, when they have a
Right.
chemical pregnancy, when they have a blighted ovum or an embryonic demise. I know I grieved and I had a
Hmm.
chemical pregnancy because it's a loss is a loss. Now, whether or
Right.
not it's considered medically in a workup and additional testing, that's different. But
Hmm.
just because we may not include it in a recurrent pregnancy loss workup doesn't mean it's not considered a loss to you. And we appreciate that as physicians, that we do understand that it is considered a loss. And it's okay to grieve any of these types of losses,
Exactly.
right?
Yeah, I mean, and like, like Dr. Clark saying, we may not include it in your workup or say like, yes, you meet criteria, but we definitely keep it in mind
Yeah.
on your history. So that way when we're kind of looking at everything and kind of figuring
Mm-hmm.
out, what's this patient's future fertility, what can we do to help her, we're definitely going to keep it in mind.
Right, right. Okay, so as far as the incidence, we know that it's common. Early pregnancy loss is common. About 80% of all cases of pregnancy loss occur within the first trimester. So about
Yeah.
80% are, early pregnancy
Yeah.
losses. And then early pregnancy loss is common, occurring in 10% of all clinically recognized. And what does clinically recognized mean? Clinically recognized pregnancy.
I mean, I guess if, something that you actually
That we see. Yeah, yeah,
right.
yeah, yeah. So it
And,
is common. Yeah, go ahead.
right. And that's the other thing that I wanted to mention when we talked about like how common this is, we want patients to realize that because it is so common, we don't want you to think like it's your fault, you did
Yeah,
something wrong. Oh, if I wouldn't have exercised that day,
yeah,
or if I
no,
wouldn't have ate that thing, or I wouldn't have
yeah,
gone on that trip, it's not your fault. It is very
yeah,
common. That's the nature of pregnancy, unfortunately,
yeah,
in
yeah.
the early stage.
Right. And I always make sure I tell patients that too. It's not your fault. There's nothing in the first
Right.
trimester losses, there's nothing you could do to prevent it for the most part.
Hmm.
And we'll talk about that a little bit too, but there's nothing
Right.
you did to cause it. And I feel like sometimes when I tell a patient,
Hmm.
this is very common, uh, I don't expect it to make her feel any better
Sure. Right. Right.
because it's, for you,
Right.
it's not common,
Right.
right?
Exactly.
But I do, even though I know it's not, but it also means I'm not dismissing it or downplaying it
Hmm.
all, even though
Hmm.
it's common. I just want to make sure that they know that, but
It wasn't their
I also
fault.
understand that it's you and it's not common for you. So,
Right.
and I do appreciate that. Okay. As far as risk factors, we know that 50% are likely due to greater than 50% due to
Hmm.
chromosomal abnormalities.
Hmm.
And
Right.
why is that? I mean, you have to have all these things come into line that everything has to work perfectly. So there's a lot of
Right.
potential areas where the chromosomes just don't match between the sperm and the egg. And that's not because of anything you did. It's just, pregnancy is, very complex. So
Right.
that's why most are due to chromosomal abnormalities. So what would be the main things that would increase your risk of having like an early pregnancy loss?
Yeah, I mean, I feel like a lot of women nowadays are, that's the whole point of your page. They're getting pregnant
Mm-hmm.
later in life. They're, focusing more on their career, and we tend to know that if you do get pregnant later in life, that increases the
Yeah.
risk of chromosome anomalies. But I think just knowing that, we still, I think doing things like this help to educate our patients. Like, even though you've had that loss and you are older, it's still possible to get pregnant, and there's ways that we can help to help you decrease
Yeah.
your risk of early pregnancy loss.
Yeah. So the most would be, again, because of advancing age and women,
Right.
like Dr. Montes said, we're having women later in life
Hmm.
pursuing pregnancies. So with
Right.
that comes along, the potential for a genetically abnormal pregnancy that results in an early pregnancy loss. And then having, an early pregnancy loss does place you at increased risk of having another one. So
Right.
that's why, we need to know exactly what happened surrounding your loss so we can determine
Exactly.
what the next best step is. Um,
Right.
you mentioned already, talked about, what things we use to confirm an early pregnancy loss. I think it's three things. It's going to be what we see on ultrasound,
Right.
what your potential pregnancy hormone level is it three things?
Hmm.
No, mainly those two. And then what your symptoms
Yeah.
are. What your
Right.
symptoms are. So let's talk about first what potential symptoms might someone be having if they're potentially going on to have an early pregnancy loss.
I mean, of course, the number one is going to be bleeding, right?
Mm-hmm.
I mean, we do tend to see that a lot in most early pregnancy losses. And also some patients do experience pain. I mean,
Mm-hmm.
even with a normal pregnancy, you can have cramping because due to just
Mm-hmm.
like everything growing and stretching and things like that. But
Mm-hmm.
of course, pain and bleeding are always going to bring a patient in the early pregnancy. You can still have, even if you have a molar pregnancy or an ectopic pregnancy, you can still have symptoms of
Yeah.
normal pregnancy because a
Mm-hmm.
lot of patients are like, but I feel like I'm pregnant. I have nausea. And I'm
Mm-hmm.
like, yes, you are. It's just that it's not a viable pregnancy.
Mm-hmm.
And so those are the things that we just have to kind of remind patients and keep them, just let them know that that's something that still you'll feel because of
Mm-hmm.
the rise in HCG levels,
Yes.
but it still could be an abnormal pregnancy.
Right. And then, based on the symptoms and what we see on ultrasound, we
Right.
may or may not choose to do pregnancy hormone levels. For me, I do do first trimester ultrasounds a lot because they come to my
Mhm.
unit for
Mhm.
ultrasounds.
Right.
Depending on, what we see on ultrasound and what the symptoms are, for me, and you may or may not,
Mhm.
you don't have to agree with me, but,
Sure.
I don't always recommend following pregnancy hormone
I
levels
don't do it
because
as much either.
yeah,
Right.
some docs do. They rely on that, and I
Mhm.
just think people get so fixated on the exact
The
number, and
number,
and it
right.
adds a lot more. Now, if I am,
Stress.
expecting to see something and they're further enough along,
Mhm.
and this gestational sac measures a certain amount, or
Mhm.
the crown rump length is, there's certain things where I might recommend getting a pregnancy hormone level, but you can
Sure.
still use it. It's you kind of decide based on the symptoms, what you see on ultrasound, and what the pregnancy
Right.
hormone level is as far as when you call it, meaning we have certain criteria that we have based on
Right.
what we see on ultrasound, whether it's suspicious for
Mhm.
pregnancy failure or diagnostic, meaning it's met these criteria, it is a pregnancy failure. But as long as the patient's okay and not having active symptoms or hemorrhaging or anything like that, we could
Exactly.
wait another 10 days to 2 weeks to get another ultrasound just to confirm.
Yeah, I feel
Mm.
like I'm exactly the same way. I
Mm.
think patients read a lot on the internet and
Yeah.
say like, but I want to know like what the level is. And I'm like, well, look, the thing is in a way the level doesn't matter at this point.
Yeah.
It really matters more how does your pregnancy look from on ultrasound
Yeah.
from like 1 week to the next. That's actually going to give us a little bit more
Yes.
information. If you have an ectopic though, I
Yeah.
am kind of a stickler on certain coming in certain days for your HCG levels,
Yes.
depending on like, if I gave you methotrexate or this or
Mm-hmm.
that, whatever the case may be. But as far as other types of early pregnancies that we're not sure of the viability of them,
Mm-hmm.
it ends up being more for me as well, more like
What
on
we see on
imaging.
ultrasound.
Yeah,
Mm-hmm. Mm-hmm.
right.
Yeah, and again, like I said earlier, ectopics and molars are managed completely differently,
Right.
and they're in a different group. I just wanted to include that, talk about it a little bit because it is considered, it is
Hmm.
something that can happen in early pregnancy that could
For
cause you to
sure.
lose the pregnancy.
Yes.
Okay, so yeah, we have some guidelines that we use.
Hmm.
Every ultrasound unit's a little bit different, but we have some that we use that, again, based on what we see as far as the size of the gestational sac, this is the
Hmm.
criteria we use: size of gestational sac, whether or not there's a yolk sac, whether or not there's an embryo, with or
Right.
without heartbeat. Based on where they fall, it could be suspicious for pregnancy loss
Hmm.
or pregnancy failure, which would require that she come back in 10 days to 2 weeks for another ultrasound. Then there's other criteria that are diagnostic, in which case, if they meet those criteria, it is considered a pregnancy loss or pregnancy failure, and then you could proceed
Exactly.
with management.
Exactly.
Okay. Now we're going to talk about management. So there are three types of management of
Let's
early
see.
pregnancy loss. We have expectant management, medical management, and
Hmm.
surgical. So tell me about expectant management. What is it, and who is a candidate for expectant
Sure.
management?
So expected management is basically where we kind of watch and wait. A lot of patients and I kind of feel like I give them the three options and I say, "Hey, look, this is what we're dealing with. I think in your case, in your scenario, I think we could do expectant management because the fetal pole or the embryo isn't super big.
Mm-hmm.
There's a good chance you could pass it on your own." And some patients, they opt for that. And I think that that's perfectly fine. You know, I think some patients don't want to be quick to rush into doing anything. They want it to just kind of naturally happen on their own, and that's perfect. You know, when we look at, you know, embryos that are further along, though, sometimes I kind of tell them, you know, in your scenario, in your clinical situation, I feel as though it probably would be better if we did a DNC on you because you're 10 to 12 weeks further, you know, along, or in this certain case, because you may hemorrhage or you may still need a DNC. So I think expectant management is great for certain patients. And if your doctor offers you that, I think that's a fine way to go about it.
And so if a woman chooses expectant management, or a person chooses expectant management, you know, there's going to be some bleeding at some point.
Yes.
And so how do you tell them how much bleeding is too much? I get this question all the time, even though I don't do it, but you know, and what is a general thing that you guys tell patients when, you know, say she chooses expectant management, and you're going to send her out the door and you say, listen, if you bleed this much, you need to go to the ER. What is this much? So this is what I tell patients. If they decide expecting management, I say the things you're going to be looking out for are what you could expect is that you will start feeling cramps, almost like contraction-like pains, and you will pass something that has like a gray, like it looks like a sac or a grayish, whitish tissue type look. And during that time, you can have, you know, pretty significant bleeding. But if it gets to the point where you're bleeding, you know, more than 1 pad an hour, during that time for a couple hours, I think that is pretty reasonable. But once your pain kind of slows down, your bleeding should hopefully tailor down as well, then you can kind of just monitor yourself. And I tend to give patients like a couple pain medicate, like Norco or something, just to help them, because it can be, because it can be pretty uncomfortable. But you know, if they continue to have pain or bleeding more than 24 hours, up to like a pad an hour, of course you need to go to the ER, because there's a risk that you still may need a DNC because you still may have products of conception that haven't passed. Or, you know, this happened to a friend of mine recently. She had an embryonic pregnancy loss, and she was fine until she stood up and it gushed onto the floor. And she had to go right away because it became an emergency. So, you know, bleeding steadily, you know, and not overfilling a pad. If you're overfilling a pad, that's different than saturating a pad. If you don't know, and you can always call and ask
your doctor's office.
Or you could just always just go to the ER if you're not certain. You don't want to wait too long. I mean, because women can come in, you know, hypotensive, needing a blood transfusion and things. And so that's the thing that as doctors, we have to make sure that you understand with expected management, it sometimes works out well and you pass everything and everything kind of happens naturally on its own. But you have to remember that there is still that potential that you still may need a DNC. You still could need a blood transfusion. You still could have other complications that happen because you chose expected management. But for certain patients, it's a very good option. I remember I had a friend, a couple of they were friends of mine, and she was also older, first pregnancy, and she started to miscarry. And he called me because he was on his way to get her some more pads. And I said, well, where is she? And he said, she can't get off the toilet because she's bleeding. And I said, turn the car around. You know, if you can't get out of bed, or you have to sit on the toilet because you can't get your clothes on because you're bleeding, you have to go to the ER. By the time he got her to the ER, she was, you know, really sick. So, you know, it's always better to, if there's any question, just to go to the ER.
Exactly.
Okay. Now let's talk about medical management. What does medical management mean?
So medical management is basically when you take a medication to help your uterus expel the products of conception. You know, for me, if some patients want to go that route, and I do have a good amount of patients that do try it, I just basically use Cytotec or misoprostol because I tend to see that it works really well. There are other options out there that you can consider. I just don't happen to use those. I tend to use the Cytotec, which is as 800 milligrams inside the vagina, and that tends to work really well for my patients. What you could expect with that is basically within 24 hours and even up to a couple hours of using it, you'll start having the cramps, the
Mm-hmm.
bleeding, the pain, and then you'll see the passage of the pregnancy. And that works pretty well because you don't have to undergo anesthesia, you don't have to have surgery. Still, patients need to understand that there's still a risk that you may need a DNC or further treatments after this, because there's a chance that everything may not expel.
Mm-hmm.
But I think it's a great option for
Mm-hmm.
certain patients,
Mm-hmm.
especially if the embryo is small.
But the one thing I have, and I agree, it is
Hmm.
a good option. But you
Hmm.
have to consider, how far away is the patient from the hospital? And there's
Right,
certain things, is
right,
she, in case she does start to bleed,
exactly. Yeah, for
you might want
sure.
to consider how far you are from the nearest hospital. And the
Right,
other thing to know too is that it is pretty uncomfortable and can be pretty
right.
painful. So if you choose that option, you may want to ask for some kind of,
And
what
I
can I
give
do
them
for pain
pain
control?
meds,
Yeah,
right?
because
Yeah.
that's the one thing I have heard.
Hmm.
It can be pretty painful. And now, is it 800 micrograms or 800 milligrams that you give?
Micrograms,
Micrograms, okay. I
micrograms.
was
Yes,
like 800
micrograms.
milligrams. That's a lot of
As
side
I said, if I said that,
No,
I
I just wanted
misspoke.
to clarify.
Yeah, yeah, micrograms.
We dose
Yes.
Cytotec in micrograms, just to
Yes.
clarify. So it's a different type of dosage.
Hmm.
Okay.
Yeah.
Yeah. So medical management is definitely an option, and I'm
Hmm.
just going to put this out. Every
Yeah.
um, physician
Hmm.
um, has, based on their years of experience, based on
Yeah.
their patient population,
Right.
based on other factors, will have their preferences on what they think is best for you. It
Right.
doesn't mean they can't offer you these things, but they may have an opinion, and it's okay to ask your doc, what do you
Hmm.
think
Yeah.
is better for me? And as long as your doc knows you the best, so
Hmm.
they may say, I think you could do either one, or they may say, because of X, Y, and Z, I think you should have a DNC, and we'll talk about that. Or because of X, Y, and Z, I think
Right.
you should do medical management. So, sometimes you can go either way, but sometimes I
Hmm.
feel like most of the time I think the doc kind of knows what they
Yes,
would,
I do. Yeah.
right? And it's okay
Yes.
for them to tell you that because they know the best. And I know some docs, some of my colleagues, they don't like to do Cytotec. I know some of my colleagues would rather not do DNCs, but everything's based
Everyone's
on, yeah,
different.
everybody's different. Yeah.
Yeah, I mean, I think it's based on like what outcomes you've seen
Yes.
in your patients that
Yeah.
you've actually taken care of.
Yeah.
For me, I kind of feel like expected management is maybe for a quarter of my patients,
Yeah.
just because my patient population tends to want to just kind of move
Yes.
things along.
Yes.
And then the other 75%, I feel as though it's about half and half.
Half and half.
Half
Yeah.
want to do, yeah, half want to do the medical and half want to do the DNC. And so, like speaking of as far, and I think we're going to go into the DNC, I
Mm-hmm.
think that is a great option for patients who really don't want to deal with
Well,
like,
but before what is a
yeah, oh, go ahead.
DNC? Tell me, what's a
Yes.
DNC?
So a DNC is a dilatation and curettage. And what that means is we dilate your cervix and then we go in. Usually I tend to use a suction DNC where it's just basically a little curette, like a little plastic suction thing where I go in and then I kind of roll it around inside the uterus, and that kind of basically clears the products of conception. I tend to try to do it under ultrasound just because I want to make sure that I get everything and nothing is left inside. And it is done under anesthesia, though it is a surgical procedure. Some offices or some practices potentially do it under sedation, like in their office and things, but I don't have that capability. We just tend to do it in the outpatient center. But patients will go home the same day. Their bleeding usually is minimal. I mean, you can have some heavy bleeding afterwards, depending on, how far along you were in things. And sometimes your doctor can give you Metrogen, which is another medication that helps to contract your uterus, right? Like for a week after or a few days after. And we also sometimes give Pitocin in your IV, and that helps to decrease your bleeding as well.
And you were talking about who you thought might be better candidates for a DNC.
Yeah, I like you said, Shannon. I mean, I feel like if you know your patient, if you know she's very anxious, if she, has been through this before and she just doesn't want to see anything, doesn't want to look at anything, and even if you haven't been through it, but you just kind of their personality because you know your patient. I feel as though some patients, I say, let's just do the DNC so we can just, kind of just finish everything, let it be a little bit more of a smoother transition for you. And I think that works well for patients.
Now, for if you pass products, like if you have something to actually pass, I just want to put this, especially doing a DNC, you can send products for testing, right? For genetic testing.
Yes, yes, yes,
Yeah.
yes. So what I do talk to my patients about is, you know, if you want to do some genetic testing to confirm that the loss was potentially due to a chromosome problem or anomaly, then yes, we can test. We can send a little bit of the products of conception that I removed during the DNC, and there's different companies that do that, and they can test the chromosomes of the embryo.
Yeah, whatever products they have. And
Whatever.
the same
Yeah.
thing can be say, I know there's been times where they actually passed and they knew that it was probably the gestational
Hmm.
sac or the placenta, and the patient has brought it in, and that could be sent for
Yeah,
testing as
for
well.
sure.
So if it's
Yes.
something that you want done, you could always ask, can we send this for chromosomal analysis, is what you would ask for.
Correct.
Okay, all right.
Exactly.
All right, so let's talk about how should patients be counseled regarding interpregnancy interval after a pregnancy loss. I know what I would prefer, and I'll go with that. So that people always ask, how long should I
Hmm.
wait to get pregnant again? You know, so I think it's two different things. If you had to have instrumentation of your
Hmm.
uterus, and Dr. Montes has to go in and do a DNC or had instrumentation, that's different because we actually have to dilate the cervix, and you want the cervix to come through and come
Right.
back together. And so they may want you, and you could talk a little bit about that. But for me,
Hmm.
as an MFM, dating pregnancies and wanting to
Yeah.
know, it's always better if you have at least one normal cycle and
That's
then try,
exactly. That's what
right?
I
But I
say.
mean, but technically you don't have to wait at all as long as
Yeah.
everything's been cleared. But I would
Yeah.
rather
I
have one
mean,
normal cycle. Yeah.
that's exactly what I say. I
Yeah.
mean, you know, the thing that's right. I mean, if you have a DNC, you know, you're at risk for having inflammation inside your uterine cavity that
Yeah.
can move
Yeah.
to your tubes, and that increases your risk of an ectopic pregnancy
Hmm.
as well. So I always make sure I give my patients just some IV antibiotics before I take them back, just to minimize that risk.
Yeah.
But yeah, I think it's good to kind of just let your body heal up, have one normal cycle, and then try again. And you know, some doctors may say 3 months, and other
Yeah.
doctors might say you don't need to wait. But I feel like
Yeah.
I go
That's my
exactly
preference
with
too.
what that's
Yeah.
exactly what I
Yeah.
say.
And it's also, if you do get pregnant, right, it's easier to tell how far along you are.
Exactly.
And it also has told me that, you know, your body's back on track and we're
Hmm.
hitting restart and we're good to go. So that kind of
Exactly.
is a general rule of thumb.
Yes.
Okay. Let's talk about, all right, this is going to be very interesting. What type of workup is needed for an early pregnancy loss? We're not going to talk
Well,
about recurrent
yeah.
yet. So you had the first pregnancy loss, whether it was an embryonic,
Hmm.
chemical, spontaneous, or miscarriage, or early pregnancy loss. What, at less than 12 weeks and 6 days, what workup do we do?
I mean, if it's just a one-time thing, I
Mm-hmm.
don't do anything really,
Yeah.
you know. I mean, it's
Mm-hmm.
like there it's just it usually most of the time is going to be a one-time thing. I mean, yes, of course there are people that have recurrent, but if it's just once, I mean, I just kind of tell them, you know, likely it was a chromosome anomaly. Go ahead and wait a month, you know, let a normal cycle pass and then try after that. And then we just kind of go from there. I don't
Yeah.
really do too much.
So, and we're going to say, we got a few more things to go through, and then we'll go through the workup if we're having recurrent, and we'll talk about that.
Yes.
Okay. So let's talk about interventions to prevent early pregnancy loss. And I just want to say, it's hard if it's you and you've
I
had the
know.
pregnancy loss
I
for a
know.
doctor to tell you there's nothing we can do.
I know.
But the truth is, there are no effective interventions for early pregnancy loss. So we've looked at pelvic rest, vitamins, uterine relaxants, giving HCG. All of those do not prevent early pregnancy loss. You talk about bed rest is not recommended for early pregnancy loss. Oops, let me go back down. I lost you. Hold on.
No, am I here?
No. I pulled
Okay.
up. How do I get back to that? There we go. You know, I know a lot of people will go on bed rest if they've having bleeding in the first trimester, but that does not help. But then we talk about progesterone. So using progesterone to prevent an early pregnancy loss is not recommended.
Right.
If you're having bleeding in the first trimester and putting on progesterone, there's no evidence that helps either. The only time that and I've posted this, it's in my infertility highlights in my Instagram, that where progesterone supplementation might help is if you have had 3 prior pregnancy losses. There may be some benefit for giving progesterone with the next one, And
Yeah.
everybody asks, well, why do I have to wait for 3? Well, because that's what the data has shown so far. It didn't show any benefit after 2. It only showed, so as a recommendation that we're going to put out, especially ACOG, that's what they're going to say. Now, your
Sure.
doctor may decide to do it after 2. That's
Sure.
their prerogative based on, that's that's their patient. But
Right.
what the evidence shows is what I just stated. What are your thoughts on all that?
You know, I mentioned that to my patient, but of course, you know, the patient is wants something done,
Yeah,
and
yeah.
I mean, it's not necessary, it's not gonna hurt. So for some of my patients, they want to do it. I say, let's just do it. You know, I've done it just at even not like after 1 or after 2, and they actually end up carrying to, you know, carrying to term. So then they say, well, maybe
They
it
think
was the
that's it. Yeah.
progesterone.
Yeah.
And you know, we
Yeah.
never know, but I feel like it's not going to hurt. If a patient wants it done, I'm okay with doing it. I mean, I did have a patient who had, well, I think we're going to talk, well, let's talk about recurrent pregnancy
Yeah.
loss, and I'll tell you about a patient that what I did for her, and she ended up doing great.
Mm-hmm.
But I mean, it's just, you never know, because you can't go back and say, if we wouldn't have given it, would you have carried or not? But
yeah, but progesterone is not a cure-all either.
sure,
And
right,
we don't know
right,
for those that it's not indicated and if it's going to cause issues. So we just have to, you have to look at the risk
right,
and the benefits, what we do know, what we don't know,
right.
before giving it. Now, I'm just going to add here, I've heard also a lot, well, fertility docs give progesterone for IVF. It's not the same thing. The reason why
Sure.
you have to have progesterone supplementation with IVF is not to prevent the loss. It's because they created the cycle, so your body is not producing it. So those patients have to get progesterone because they don't have the corpus luteum cyst that produces progesterone until the placenta takes over. And I did videos about what the corpus luteum does. Sorry, not the corpus luteum cyst, the corpus luteum. And that's in a normal or spontaneous conceived pregnancy. So since IVF pregnancies are not spontaneously conceived, they have to be given progesterone. So that's not the same thing. Okay, so progesterone is not given for IVF to prevent pregnancy loss. It's because the body is not making it, and they have to provide that until the placenta takes over at around 13 weeks is when they stop giving you the progesterone. So it's not the same thing. Okay, so yeah, the whole progesterone argument. I mean, it's I don't do this for patients because my patients are already pregnant. But as someone who's been through a lot, I can get it. I get it.
I know.
It's tough. It's tough. It's tough, but just talk to your doc, and every doc is a little bit different about what they feel on progesterone. But that's why it's important that you have a good interaction with them and talk to them about what their thoughts are.
Right.
Okay, so let's talk about recurrent pregnancy loss. What is recurrent pregnancy loss? So this is a condition when a woman has 2 or more clinical pregnancy losses or miscarriages before 20 weeks of pregnancy. Now, this is not the same as someone who comes in with cervical incompetence, and we're not talking about cervical incompetence.
Right.
That's a different ballgame. The progesterone is different. Everything is different. Maybe one day we'll address cervical incompetence, but cervical incompetence and spontaneous pregnancy loss that's different. Even though you can have cervical incompetence at less than 20 weeks, it's a different mechanism that causes that. So we're not including that in this conversation, right?
Right.
So it's
exactly. Yes.
Okay. So basically, the clinical pregnancy, as we talked earlier, what that means, it's diagnosed by a healthcare provider using ultrasound. So you do see something on ultrasound, that means it's a clinical pregnancy loss. We've already talked about whether or not they're considered losses. So what are some of the causes of recurrent pregnancy loss, which would be 2 or more consecutive, meaning back to back? So if you had, and this is another thing, if you've had 4 pregnancies, you had an early pregnancy loss, then a full-term pregnancy, then an early pregnancy loss, then a full-term pregnancy, that's not recurrent. It has to be back to back. Okay.
Right.
So what are some of the causes of recurrent pregnancy loss?
So, of course, the chromosomal anomalies, we always think of that. You also could have a structural issue with your uterus, like a septum or something that isn't allowing the pregnancy to implant. You could have an issue with like clotting factors or clotting in your blood. And also, certain antibodies and things that can make you have the recurrent pregnancy loss.
So there's multiple things.
Yeah.
But and this is also a hard pill to swallow sometimes.
I know.
Over half, probably even more than that, in my experience, of recurrent pregnancy losses have no reason.
I know.
And
right.
we always want to get a diagnosis.
I know.
And I hate not being able to do that. Even if we did the $1 million workup, over half, we cannot find the cause.
Yes.
Okay, so even if you did testing and the chromosomes are normal and you tested the products, over half of recurrent patients with recurrent pregnancy loss have no known cause. So, and I understand that's all, you don't want to hear that. You want to know
I
because
know.
I think people feel that if they have a diagnosis, then there's a cure for it.
Yes,
And I get
exactly.
that, but unfortunately, in over half of the cases, we don't have a diagnosis. But you talked about genetic, and we've talked about genetics a lot. The chromosomes, and
Right.
obviously, if you're at advancing age, that's one of the risk factors. For the anatomic, you talk about when the cavity of the uterus is supposed to look a certain way. I can't do it with my
Mm-hmm.
finger. It's like a
No,
little
like a
a little
little,
triangle,
yeah,
ideally.
yeah.
And if you have septums, if you have things that are distort the uterine cavity, if they're
Or a
fibroids,
fibroid, right,
anything
exactly.
that can distort, if you have uterine anomaly, and there's a bunch of
Exactly.
different things where the uterus doesn't develop like it should and it looks different. Those are all
Mm-hmm.
things that can contribute to recurrent pregnancy loss.
Exactly.
And you mentioned smoking earlier is definitely a thing.
Mm-hmm.
And then certain recreational drugs. If someone is a cocaine user,
Mm-hmm.
and they're doing certain things like that can cause pregnancy loss, and I've seen that as well, and I'm sure you have as well. And
Right.
then being overweight has been
Yes.
really linked to recurrent pregnancy loss and other pregnancy complications. So maternal obesity does have an effect on pregnancy loss and recurrent
Right.
pregnancy loss. And then excessive alcohol or caffeine intake potentially, that's hard to, it's possible, but
It has been
what
studied,
it
but
has been said, but what's excessive caffeine? And the whole thing with alcohol is, and this is a whole nother discussion.
right.
We know that you can drink just a little bit and have problems, or drink a
Right.
lot and not have, I mean, it's
It just depends on,
the
yeah,
person.
you never
So,
know.
but that's just because we know that, definitely we know that there is fetal alcohol syndrome, fetal alcohol effects. That's why we
Right.
recommend no alcohol, because it
Right.
is such a spectrum. But we don't have that same thing for caffeine. That's why we haven't spit caffeine off the table. We recommend 200 milligrams a day or
Right.
less, because we
Right.
don't have caffeine syndrome or anything like that. It's
Right.
different. So alcohol and caffeine are different. And
Right.
then you talked about, one of the biggest things I see is
Mm-hmm.
diabetes.
Mm-hmm.
Maternal
Yeah, for
diabetes
sure.
causes
For
recurrent
sure.
pregnancy loss. There is no question.
Yes.
Babies cannot develop, pregnancies cannot progress in a
In a
hostile
high sugar
environment
state.
with
Right.
this high sugar state. So
Mm-hmm.
that does cause recurrent pregnancy loss.
For
Okay.
sure.
So
For
if you
sure.
have untreated thyroid disease as well,
Exactly.
if you have medical conditions, the time to get them under control is not once you get pregnant. It's before you get pregnant, right?
Exactly.
In order to have the best outcomes.
And a lot of patients get especially like PCOS
Mm,
patients. A lot of patients or PCOS patients get pregnant just by losing weight, and so
yes.
that right there, I
Yes.
mean,
Mm-hmm.
not
Mm-hmm.
saying that we're talking about infertility, but that
Mm-hmm.
still has something to do with kind of what you said.
Yeah. Okay, so now let's getting into the testing. What tests do you have? Someone that's had two recurrent, say three
Mm-hmm.
pregnancy
Mm-hmm.
losses
Yeah.
back to back. They fall into the category or the classification of recurrent pregnancy loss. How do you start your workup?
So, I mean, I do tend to start with the antiphospholipid antibody syndrome workup, just because that's, an autoimmune disorder, and that tends to be something that it's not super common, but we just kind of want to rule that out because we know that definitely can cause that.
So for thrombophilia
Mm-hmm.
means blood love or clot loving
Yes.
is what it translates into. But
Right.
what it means is you have a propensity or something within your body that causes you to clot easier than
Exactly.
what is recommended. Yes, we want your blood to clot. If you get cut, we want you to clot.
But not
I mean,
over.
yeah, but not over clotting and not clotting for
Mm-hmm.
no good reason. So that's where
Exactly.
thrombophilia. Now there's a whole range of thrombophilia workups, factor V light, and we're not going into that.
Yeah.
But for first trimester, early pregnancy loss workup, the only one that is recommended is the antiphospholipid antibody syndrome workup, not everything else. That's different.
Yes.
And there
Yes.
we use laboratory for antiphospholipid. We'll talk about that. Where did it go? Just so I can throw that out there, how we diagnose it.
Yeah.
The diagnosis requires at least one clinical, meaning one, whether it's recurrent pregnancy loss
Mm-hmm.
or you've had clotting, and one laboratory. So there's a whole thing that we use. There's guidelines that we use to diagnose
Yes.
antiphospholipid antibody, and then we also look at your blood for different antibodies like anticardiolipin antibodies, glycoprotein antibodies, and lupus anticoagulant. So those are
Right.
different things that we use to work up. And you need to have at least one of the clinical and one of the laboratory
Mm-hmm.
criteria have to be met.
Mm-hmm.
And antiphospholipid is a whole nother talk too.
Oh
And
my God, it's so
it
complicated.
is
Yeah, I
complex.
mean, yeah,
Yeah.
I had a patient who had actually three 3 recurrent losses, and and then I was able to finally do this on her, and she actually didn't, her like anticardiolipin it's supposed to be 40, hers
Yeah.
was like 25, but I actually still ended up putting her on, just prophylactic Lovenox, and she ended up delivering at term. So, I mean, she wasn't exactly on the cutoff, but she had that history, and she was kind of borderline. So, I mean, you just have to look at the whole clinical situation.
Yeah. And then one of the things I want to say is the use of anticoagulants, which would be like Lovenox or heparin,
Right.
aspirin, or both, has not been shown to reduce the risk of early pregnancy loss in women with thrombophilia, except in women with antiphospholipid antibody.
Yes.
Okay.
Yes.
So
Right.
that's important to know too. So we're going back. That's all with antiphospholipid. Okay. The other thing that you can do is send them to a geneticist, a genetic counselor.
Mm-hmm.
Because, and I do that a lot, actually. Even though I'm trained to do genetic stuff, I'm not a genetic, I didn't do my fellowship in genetics. I can do so much, but they can look at your history, your partner's history, to see if there's anything that might, and these guys are like little sleuths. They can figure it out, right?
Yeah, they can find all kinds of
stuff.
Yeah.
I use them a lot. We use them a lot. And one thing they'll likely do is recommend a karyotype on you and your partner. Karyotype means they're going to look at your chromosomes and his chromosomes, or their chromosomes, to see if there's something in your genetic makeup and or your partner's that is not allowing a pregnancy to develop. And even though you have nothing, medical
physically wrong,
physically, there might be something within your chromosomes or theirs that doesn't allow. So that's one thing. So we talked about screening for antiphospholipid. The parental karyotype is what that's called. You need to look at thyroid disease to make sure the thyroid's normal.
Yes.
Look at prolactin, make sure your prolactin level's normal. And then we already talked about looking at the chromosomes of the products of conception for any pregnancy losses that you had, if you can. Let's see. The other thing, once you get to the recurrent pregnancy loss thing, and I talk about this every chance I get, incorporating therapy into this to help the patient get through this is also essential. So counseling and support is also important, because going through miscarriage after miscarriage is not easy.
It's not.
And having therapy and counseling is crucial. So we all have therapists and counselors that we all refer to.
Right.
And you could just ask your doctor, hey, is there a therapist or a counselor that you recommend? But the other great resource is going through your insurance provider. Yes. They all have that. They know they take your insurance, and they know that, what kind of therapy, what their specialties are, and they can refer you. There are a lot more counselors and therapists going into infertility therapy and counseling.
Yeah.
So there's a lot more of those available than there used to be. So, or seeing someone such as a perinatal psychiatrist that specializes on everything for mental health regarding pregnancy and fertility, postpartum, all that. That's their area of expertise. I highly recommend that, because even though your mental health may not be what's causing your miscarriages, it's definitely not going to help if you have additional stress on top of that.
Exactly.
Worries, right?
Yeah,
so what are your thoughts on that?
Yeah. I mean, I think sometimes some doctors tend to not look at the entire patient like as a whole, but we do have to definitely look at your physical and your mental health, because they play a big role amongst each other. They're intertwined. And like Dr. Clark said, if your mental health isn't where it should be, your physical health is going to suffer, and then that's gonna make it even harder to get pregnant. And I definitely agree with everything you're saying.
Yeah, I want to spend a few minutes answering questions. We're gonna have to do a part 2 because we're running out of time, and
are we? I don't even know what time it is.
I know. I looked up and it's like we have 7 minutes left. So
wow.
Yeah, I know. So this is what we're gonna do. So first, as far as treatments for recurrent pregnancy loss, it depends on what the workup shows, whether or not what the treatment is available. Okay. And then the other thing I wanted to answer real quick: will I be able to have a baby even with a history of recurrent pregnancy loss? And the data is, it says even after having 3 miscarriages, a woman has a 60 to 80% chance of conceiving and carrying to full term.
Right.
And that's
so it's still
hopeful,
high,
but it still doesn't make it any easier when it's you.
Right.
Okay. So yes, there's still a chance that you can conceive and carry to full term even after recurrent pregnancy loss. So Dr. Montes, I'm going to hold you to a part 2, because I want to discuss subchorionic hemorrhage and some other things.
Yes.
After this. So we'll schedule a part 2. So let me go through and see if there's any questions.
Yeah, I think we had a good amount.
I know, and we're not going to get through
I
all
know. I'm
this.
sorry, you guys, but yeah,
So
I
guys,
love
if you,
talking about this. I
yeah,
appreciate.
if we don't get to your question, what you need to do when I post this video under my feed, because if you do a question under my stories, it gets lost. You have to put it under my feed. You have to put it under my feed so we can answer these questions at the next one. Do biochemical pregnancy loss occur from one woman taking oral contraceptives since the lining is affected? No, that oral contraceptives is not going to affect your. I don't know that's what you're asking, right? Your chances of having a
I'll
chemical
let you
pregnancy.
look at them. Yeah, because I
Yeah.
can't go through them
Okay.
like you are.
Are chemical pregnancies indicative of potential male DNA fragmentation? So that's not a question for me. Have you heard anything about that?
No, but I mean, I think that's where those genetic counselors
Yes.
really come into play.
Yes. So, and that's also something that the fertility specialist. I, as an MFM, Dr. Montes is a general OBGYN. We do not, for recurrent chemical pregnancy loss or biochemical pregnancy loss. But you might want to ask to see a geneticist.
Right.
And you might want to see a fertility specialist to see what their thoughts are on that. Because I know fertility specialists, and I've talked to a few before this conversation. What do you do? Do you do workups after recurrent? And I don't even know if there's a definition for recurrent chemical pregnancy loss.
Right.
But some of them did say yes, they will pursue a pregnancy loss workup, but it would be the same as what we just mentioned. So I don't know if it's any different. So that's a good question. Okay. So can you talk about the workup differences for recurrent pregnancy loss for someone who's having losses at 6 to 7 weeks versus those at 9 to 10? It's the same. So recurrent pregnancy loss workup is for people with losses before 12 weeks and 6 days.
Yeah.
Okay.
Exactly.
Can you also discuss yeah, so we already talked about that. Can you discuss if a woman can get pregnant but has had 2 miscarriages before 7 weeks? And I just talked about that.
Yeah, you just gave the stats right there. Mm-hmm.
I'm going to hit on this real quick. The vanishing twin. I get that question a lot. What's the most common cause of a loss of a di-di twin before 13 weeks? Vanishing twin. Twins are not a normal pregnancy from the get-go. It's not normal.
They're complicated.
Unless you're, in the humans to have more than one baby. It happens, but it doesn't mean it's so there's different set of complications. So vanishing twin typically occurs for one of two reasons. If it's early, it's likely due to chromosomes. Okay, because not only do the chromosomes have to come right for one baby, it has to come right for 2.
Exactly.
And then sometimes if it's a little bit later than that, it's because the placentas have to compete for space, and they may not get the same nutrients and
basket blood flow and all that.
The acreage on the uterine wall that they need to develop. So those are the most common causes. So earlier on for a vanishing twin, it's likely due to chromosomal defects.
Right. I agree with that.
You see us circling? We're not going to talk about cervical stuff today.
What did it say?
Something about cervical length. And I saw cervical length. So that's a whole different. We can't get into that in 3 minutes. After expectant management, how long would you expect to see your HCG level decrease back to pre-pregnancy levels?
Well, it depends on how far along you were and how high it was, but I tend to, it's really difficult to say, but for sure within, a month. I mean,
but that's why I think it's still good to just have that first cycle, because when you have that first cycle, then you're kind of resetting. Does that make sense?
Exactly. That's why I think we agree on that for sure.
So the only time when we would I got 2 minutes left, follow your pregnancy levels till they're gone is with a molar pregnancy. Okay, because we need to make sure
ectopic.
And ectopic. So we need to make sure that's out and it's been cleared out. For the rest, we don't have to follow that to 0. That's not necessary. So the best indicator that things are resetting is if you have one normal menstrual cycle and you kind of reset. Okay.
Exactly.
All right. Is it common to see reduced menstruation bleeding after a DNC? Do you know what she's talking about?
Maybe does she mean like in her normal, maybe in her new period?
Yeah.
I mean, I wouldn't. I don't think. I mean, I think you could, but I don't necessarily think it's like I think you could see it or you couldn't see it. It's hard to say.
Okay. So listen, I got 1 minute left, and then we're going to stop. The whole thing with progesterone. This is the whole thing with anything. You can find a study and a paper that supports
that goes
anything.
for it or against it.
But
Yeah.
the goal of ACOG, which are for our governing bodies for fertility and pregnancy, we have ACOG, SMFM, ASRM. Their job is to take the evidence in total and review it and give a recommendation to help guide us in some ways. So I'm going to tell you, and I'm sure Dr. Montes, and then you can agree or disagree.
No.
I do not change my practice based on one article.
Yes,
because I would
sure.
be changing my practice every 5 minutes.
Right.
It's impossible to do that. So although there might be an article that progesterone is key, that doesn't mean that it is.
Right.
Okay, you have to look at how the study was done.
Right.
If it was powered enough to make a difference, because a lot of studies are not powered and they can make a suggestion, but they can't do a definitive recommendation.
It's not statistically
significant. So
you
have to understand, just because you can go on Google right now and find an article to support your stance, it doesn't mean that it's right. Okay, we have 4 seconds left. Thank you.
Okay.
I appreciate
Thank you, honey.
Part two.